She has a lot of academic laurels to her, past president IACTA, then general editor, and many author of many journals and books, and takes part in many conferences actively. Thank you, ma'am, for being part of it. For this, we have Dr. Venkat Goel, Dr. Pranay Oja, Dr. Sundar, Dr. Sunil Kumar Pubani, Dr. Jagdish, as part of the panel members. Welcome you all. Over to you, ma'am.
A very good morning to all of you. It's indeed a pleasure to be a part and parcel of the MGM hospital. As a cardiac anesthetist, so used to the MGM holiday that we would have as an update in Chennai with Dr. Raju and Dr. Naidu, as well as Dr. Mahesh putting in an MGM hospital of Dr. Balakrishnan, Suresh, Murli, and the entire team gathered here, lovely lectures, is indeed a big, big privilege. Thank you, Dr. Suresh and others, for giving this topic, which is very, very dear to most of us, because it's an enigma. It's an enigma because we don't know where we stand even today, as Dr. Lakshmi was pointing out early in the morning. But I'm privileged to be amongst the most elite as my panelists, and I'm sure at the end of this panel discussion, we would have at least reached some statement as to where we are today at the end of 2021 in anticoagulation on ECMO. So I have with me Dr. Pranay Oja, needs no introduction, the backbone of the ECMO Society of India. He is a ECMO specialist at the Riddhi Vinayak Multi-Speciality Hospital, Mumbai. I call him the flying ECMO specialist because wherever you need any problem, I've seen him last 20 years, he is there with his ECMO machine and team. Dr. Jagdish is the other panelist. He's yet to join us. He's a senior consultant cardiac anesthetist at MGM Healthcare, Chennai. Dr. Jagdish, can we have you? Good to see you. Dr. Venkat Goel is the third one here with us. He is also at the Riddhi Vinayak Center along with Dr. Pranay. The two of them work in tandem and are a big team, and he is the former president of ECMO Society of India in 2011. And he is the former president of ELSO, the co-founder of ELSO, along with Dr. Sunil Pubani, who is with them, and I work with all three of them last at least 14 years I've been with them. And what I have learned from them is this: never say no to any work. Dr. Sunil Pubani is now at Abu Dhabi. He is a pediatric intensivist, ex-president of the ECMO Society of India, the founder chairman of the ELSO, a divisional chief with the Department of Cardiac Critical Care, MBR University at Dubai, and his area of interest is ECMO, pulmonary critical care, and pulmonary hypertension. Last but not the least, it's a proud privilege to introduce Dr. Sundar, from whom I've learned so much on transplant, and it's a big privilege to have him here as a panelist. He's a senior consultant cardiac surgeon for heart and lung transplant at the Apollo Hospital, Chennai. And I think to all of us here, needs no introduction. So with this big panel coming up, let me start with my first round. We have 4 rounds, keeping the time in mind. And with all of them, let's see where we stand. Dr. Venkat Goel, the first question is to you. What are the options for anticoagulation on ECMO? We know that ECMO brings about anticoagulation, and we are so used to using heparin. Your thoughts on anticoagulation today?
ECMO, as you know, is a great thrombotic source, and we have only one drug which is widely used as heparin. Apart from heparin, because of its some limitations, there are other drugs in the market are direct thrombin inhibitors like pyridine, biliverdin, agrabatan, desuridine, lesuridine, and oral even direct thrombin inhibitors like dabigatran is available in the market now. We do not have much experience because they are not available or they are costly, and the first line drug always remains the drug of choice is heparin.
While we are on heparin and having used low molecular weight heparin so much in COVID-19, would you agree that ECMO could be done with low molecular weight heparin?
Two things. one, we do not know the exact dose, and there is no reversal. So these two things limit us about the use and the acceleration and the deceleration. So for a small antithrombotic activity like a PCI or other things, low molecular weight heparin may be better. For a continuous round-the-clock antithrombotic activity with low molecular weight heparin may not be complete.
Anyone with any other alternative anticoagulant they have tried on ECMO? Neformistat, anyone? Neformistat, mesylate? No. Well, at a dose of neformistat is a sealant, and at a dose of 30 milligram per kg body weight, there are at least 5 to 6 reports which have just come in to say that it replaces heparin and is as good to go on veno-venous ECMO. Only 3 case reports, no original study yet, so we cannot say with success, but then an alternative of neformistat is available. The second question is to you, Dr. Pranay. What are the dosages of the anticoagulants that you give on ECMO? Could you just tell us what would be the dose of heparin, what would be the dose of bivalirudin, and what would be the dose of, let's say, argatroban?
See, basically, the dosage of anticoagulants we use depends upon the condition of the patient. Whether patient is coagulopathy to start with, so the weight of the patient and the overall condition of the patient, whether patient is post-surgical or whether, so everything depends on that. Usually the loading dose of heparin is we give is either 50 to 75 milligram per kg as a bolus dose when we put a wire inside. The moment the wire is secured, we give a dose of heparin. And then to maintain the heparin, it is usually around 10 to 20 units per kg per hour. So that's what usually the dosage we do. We maintain the ACT around 160 to 180 in most of the cases. But again, depending upon the thrombotic or bleeding, we might have to alter the ACT. We might have to make the ACT say lower if there is a bleeding, so might keep it around 140 to 160. Or we increase the ACT if there is a thrombotic tendency, and if we find there are clots in the oxygenator or circuit somewhere, we increase it to say 180 to 200. So that depends upon the case to case. Bivalirudin doses usually, if it is started as a bolus dose initially, then we give 0.5 milligram per kg as a bolus dose, and then we maintain it around 0.2 milligram per kg per hour as a maintenance dose. But if it is started a post heparin, we have started with heparin and then we switch over to bivalirudin because of suspected heat or something, then we usually reduce the bolus dose to 0.2 milligram per kg.
Argatroban is another very good drug which we use in the Cath lab. Many people are using it. Anyone with any indication of the use of argatroban? Well, did try it post PCI on a patient and without giving anything. This was the doctor's husband, and this is about 10 years back. And the patient did very well with just heparin bonded circuits. This has been again a case report written, but the patient died within 24 hours. So we don't know much, but these are drugs which are coming up. These are alternatives to heparin, and I think the era very soon would be having a nitric oxide polymerized biosurface of the ECMO circuit, which is not just low dose heparin bounded to maintain the ACT and the APTT within normal limits, but which does not cause much bleeding as well as thrombosis. Our third question is to Dr. Sunil Puvani, sir. With your experience, how would you monitor the anticoagulation on ECMO, and what laboratory parameters would you use with their normal ranges, and do you consider antithrombin 3 monitoring as important?
Thanks, Poonam. As you said, the guidelines are anticoagulation are evolving, and still there is a lot for us to understand. As Ravi Tyagarajan sitting on the panel, he also keeps telling about this. It is evolving and there is a lot more for us to understand. As far as the available information goes with respect to the heparin, the most common drug that is being used, the advantage is it has a reversal and it can be measured bedside. So the frequency does vary with this. Before the patient is stabilized on anticoagulation and heparin, we tend to do hourly, then make it 2 hourly, 4 hourly also. Once stability state has achieved. We have tried with the Actylite and Hemocron missions in the bedside practice, but what we have noticed is there is a slight difference from mission to mission as well, from company to company as well. So though we say ACTs of 160 to 180 for veno-venous and 180 to 200 for veno-arterial, it might need little bit. It might change a little bit depending on the mission which we have been using. The other measures are, since morning we have been hearing about it, about antithrombin assay, besides APTT measurement and factor 10A assay. These are the anti-10A assay, these are the other things. Especially for the factor 10A assay for direct thrombin inhibitors, this is the measure we tend to use it. It is not a bedside test. There are some fallacies with that as well. In neonates, it is not very reliable, and with respect to APTT, when the C-reactive protein is very high, then also APTT value is not reliable. My colleagues will be taking on further regarding the thromboelastogram and all. These are the other measures
but
that would be
APTT,
useful.
what level would you think is good for neonate versus an adult?
We tend to use between 50 to 90 seconds in
For
the,
adults.
yeah, that
So
is the range.
I would like to keep 60 to 80 for neonates and about 50 to 80 or 50 to 90 for adults. Anyone differs in their APTT values? But generally between 60 to 80 is what we consider normal on an APTT. And when we do APTT, or we do anti-10A, or we do antithrombin 3, these are difficult tests to do. In the West, you could do these tests twice in a day. But in our setup in India, even in a place like AIMS, getting an APTT done once is tough. So we do it every alternate day if we have to on a very bleeding patient. But at the same time, one must remember that ACT alone is not enough. Anti-10A is a better relation to heparin levels than ACT. And at the same time, APTT gives you much better results. And remember always, these are all plasma-based tests. These are not platelet-centric tests. So the moment your patient has thrombocytopenia and the blood count and the platelet count is less than 50 or less than 45, your patient is bleeding, then these tests do not suffice. Would you agree, Dr. Sundar?
Just
Yes.
a word about antithrombin 3, Poonam. While I was in Canada, we were doing antithrombin 3 regularly, especially when heparin infusion rate goes up and you suspect antithrombin 3 deficiency at that time. It is not, the test is not available everywhere. You presume antithrombin 3 may be deficient and you tend to give it by FFP or by synthetic antithrombin 3 as well. And the synthetic antithrombin 3 is also not available in many places. FFP 1 ml gives 1 unit. So you have to estimate the levels of antithrombin 3 to keep them above 70%. You calculate the deficit, and from there you calculate the dose of antithrombin 3 to be given. Accordingly, you can use it. The problem is with respect to the measurement and the availability of the antithrombin 3, these two.
Yes.
So recently, with the information we have been hearing from Canada again, Gail Anich and others, the information is like, even though you give antithrombin 3, the therapeutic benefit is not that much, so it is better to use higher doses of heparin apart from chasing the levels of antithrombin 3.
Yes,
So the school
agree.
is debated over, thoughts are debated regarding this management. One can do either. If antithrombin 3 is available, that can be given. Otherwise, there is no harm in increasing the dose of heparin to the requirement and use it.
Very rightly said, because antithrombin 3 with heparin makes the antiplatelet activity, anticoagulant activity 1000 to 2000% more. Heparin has no inherent direct action of anticoagulation. It binds with antithrombin 3. And at all times, keep antithrombin 3 levels above 70%. Some papers and books also write above 80%. And keep the anti-10A level between 0.3 to 0.7. Less than 0.3, less than particularly 0.25 is a problem. As we talk about the levels and these monitors, we enter an era of direct thrombin inhibitors. So Dr. Jagdish, what are the alternatives to heparin in a case of heparin-induced thrombocytopenia? Dr. Sunil said that heparin resistance, heparin-induced thrombocytopenia sets in very high when you're giving heparin for a long time, particularly in pediatric patients. How do you obtain that, and is there a role of direct thrombin inhibitors?
Yeah, there is a role for direct thrombin inhibitors in proven cases of HIT. The first step is to stop heparin and then start them on direct thrombin inhibitors like bivalirudin, lepirudin. So what we have seen, we don't have directly seen full-blown HITs, but some patients, they had antibodies to this heparin platelet 4 complexes. But clinically, they didn't show the severe form like thrombus or necrosis like that. So if we see decreasing platelet count once the heparin is started, or if we see heparin resistant, we start direct thrombin inhibitors like bivalirudin.
Okay. What then are the advantages of the use of these? We did the laboratory classical tests where you send the test and maybe it takes 4 to 5 hours for the result to come. What are the advantages of faster turnaround tests like point of care tests like Rotem, Sonoclot or TEG while we are on ECMO? Dr. Sundar, to you.
Thank you, Dr. Poonam. Yes, as you rightly said, the point of care, the test is available at the bedside, so it helps us make instantaneous decisions. By and large, in all routine ECMO runs, the first 2 days we use ACT, and once we stabilize, we go to APTT, which takes a minimum turnaround time of 3 to 4 hours. So it is predominantly when we have some complications where APTT, for the reasons we all discussed before, alone is not enough. Then other tests looking at the fibroelastic viscous properties of blood and blood clotting could help. And the one thing that we use in our unit is TEG, which is probably the most common one, thromboelastogram. And based on that, we would be able to address coagulopathy.
So do you think having them in every ECMO patient is going to be helpful, and should we have them? Because in trauma patients, in certain bleeding patients, the level of evidence given by most guidelines on patient blood management call them as level of evidence 2A. Do you think we need these expensive tests in our armamentarium on an ECMO patient who's already paying so much for the ECMO?
I would be inclined to agree. Already we are giving an expensive therapy, a very invasive therapy as it were. And so to have this in the armamentarium, probably one of these.
Would be. I
Would
would
you
say
agree,
it is a
Sumit?
must. I would say it's a must.
Yeah.
Yeah,
In a
Dr.
high
Sunil
volume
agrees?
center, probably we should have it. That will be helpful.
So tertiary referral centers should have at least a sonoclot, which is not expensive. A double channel sonoclot has an ACT cartridge as well as a sonoclot cartridge. It has the heparinase cuvettes. You can put your 0.4 ml of the patient's blood, run it for 10 minutes and see the platelet function come on very beautifully with the clot retraction time and the residual heparin effect also not said. So that doesn't cost money. Our normal thought is that all these point of care tests are expensive. But believe me, if you see the length of stay of a patient on ECMO vis-a-vis the message that these tests give you and the cost that they cost, I think it should be at least a level 1B from the Indian scenario point of view, where sepsis is as bad as bleeding on an ECMO patient.
I just have one question on HIT, diagnosis of HIT. It is to the floor and the panelists. How easy is this for you to diagnose HIT? And how accessible is this assay for antiheparin? Where do you do it?
We do it and the result comes after 2 to 3 days. By that time you may see some gangrenous changes in the toes of the patient because you've given so much of heparin already.
In fact, I feel in Indian population we see very rarely a heat.
Yes.
In fact, I have hardly seen in 1 or 2 patients of ECMO
40 patients per
proved
1,000
heat.
they say.
Yeah.
Even in UK, Poonam,
Yeah.
1%
No, not
is
much.
the incidence I have seen for
Yeah.
the heat. From the ELISA test, detection of the antibodies against platelet factor 4, it is non-specific. False positivity rate is quite high.
So actually
it is
what
only
we
the
see-
serum serotonin serotonin release assay, that is the one which is specific and sensitive. So we probably overdiagnose HIT compared to what the actual incidence is.
Yeah,
I think
I
what
agree.
we see is more of heparin resistance.
Yeah,
and-
more we see heparin resistance compared to
and
HIT.
we
Yeah.
don't resort to the antibodies on a routine basis in most of our patients.
And there are many factors for the platelet numbers to go down. It's multifactorial.
Yes, hemodilution and hypothermia being one of them. Simple things like
Is it
sepsis.
available
Sepsis.
in India? The last time we sent it to Singapore.
Yes, PF4 antibody test.
No, it's
Right.
PF4 antibodies have been done in India.
It's been done.
We have,
been
in
done,
some specialized hematology labs, they do it. We have 2 of them in Delhi. They have one of, we have one in AIMS only. We go on to the next round, which is the round dealing with the different types of ECMO and how they bleed. Dr. Venkat, to you, how do you identify that the patient on ECMO is going to be at risk for bleeding? And in your experience, what bleeds more, the veno-arterial or the veno-venous ECMO?
If we classify bleeding, then it can be at the local cannulation site, or it could be related to a procedure like tracheostomy, or a small surgical procedure like ICD drainage, or it may be part of the surgical ECMO where thoracotomy is there, or it may be an endocavity bleed. Now this topic comes in relation to an unexplained sudden endocavity bleed where the patient is going towards the risk of an silent endocavity bleed is very difficult to diagnose. What I feel is there are some hints from the patient hemodynamically or clinical deterioration that should give you a herring sign or a red alert that you need to look on all the fronts. If I would say that the total risk of bleeding is around 3 to 7% of endocavity bleed and on average 5%, then even though when they bleed, we feel the patient was not good for 2 to 3 days earlier, and we never did a very extensive hematological assessment of these patients to control or to avoid that bleeding. And once it comes, then probably it is all a defensive mechanism, and we try to correct whatever is left over, but a very robust protocol is required at each center to have a proactive assessment of the risk of bleeding to be identified on clinical basis or deterioration of the patient. If I have to say, hemorrhage is more in VV ECMO and clotting is more on, hemorrhage is more on VA ECMO and clotting is more on VV ECMO.
I agree with you. VA ECMO patients bleed more because of so many reasons. Any experience from you, Dr. Pranay, why do the VA ECMO versus the VV ECMO bleed more?
See, the commonest reason for VA ECMO to bleed, one is we are keeping acetone on higher side, but we are always worried about systemic embolization. Second is we are Second is we are cannulating the arterial side. So the cannulation side bleeding is going to be, even your nick is little more or something, then the cannulation side bleeding is going to be more common. Third is they are, most of the time they are hypotensive, so they have some ischemic gastropathy and that sort of thing. So they again bleed, the incidence of bleeding from the stomach and is going to be little more. And if they go in a cardiac stunning, again the pulmonary hypertension, and that can lead to bleeding in the, might lead to pulmonary hemorrhages.
Totally agree. Any one of you, why do them, sir, Dr. Sundar, why do the VA ECMO bleeds more than the VV ECMO in your
Well, the
experience?
first thing I would agree with what Dr. Oza said, you're having a higher ACT,
Yes.
number one. So
in your transplant patients, cardiac transplants, do you see more bleeding?
I
We
wouldn't,
don't.
no, nothing in particular.
And Dr. Jagdish, your experience on VA versus VV?
Again, I mean, VA ECMO patients, they bleed more than VV, as I said. I mean, ACT is maintained at a higher thing. And,
Dr. Puvani, VA versus VV in children, which bleeds more?
Again, same principle applies, Poonam. VA little bit more than that, but it is needed to maintain ACTs at a higher level in VA to minimize the possibility of thrombosis within the lungs. So we agree with that. But as an observation, VA bleeds more than the VV.
One more thing I just want to add is many of times when we start with the VA ECMO in a cardiogenic shock, many of them has got a hepatic congestive megaly and hepatic dysfunction. And many of them have got elevated PT-INR. So again, that adds into the bleeding complaints. In fact, there are papers which say that if the INR is more than 3 and at the initiation of ECMO, or VA ECMO, the survival chances decreases in that
I agree.
case.
In fact, Dr. Balakrishnan asked Dr. Lakshmi a very pertinent question. ICH, what are the markers? And I personally, she talked about PCO2 changes. I think PCO2 changes, your gases tell you that this patient might bleed. Your basic CES will become from -4, -10, -12. And there'll be pH less than 7 suddenly. The PCO2 would be fluctuating between a hyper as well as a hypocapnia, more towards the higher side, and your PO2 would come down. These are changes for which I personally feel, while we are in the OR particularly, and we are doing an integrated ECMO in our system, that this is the time when you should go ahead and do an echo if the patient is not yet on bypass. We use integrated ECMO to keep the patient on bypass, and we come off on the ECMO. While we were doing this, we realized that if we've done an ECMO in the echo on this ECMO patient in the post-op period, you would see some migration of the cannulas as well as some oozing and casts around the cannulas. They may not come on the first, second, third day, but third, fourth day, you'll suddenly see oozing around the cannulas. These are other markers that your patient might bleed. But going on to our second question to you, Dr. Pranay, what are the limitations of conventional coagulation tests in bleeding management on ECMO?
See, the problem with the conventional coagulation test, especially with the when the patient is little on more days on ECMO, is you find there's a discrepancy between the APTT and ACT levels. So that is the one thing which we find. Secondly, they have a thrombocytopenia, and they have probably, if they are going in sepsis, they have some coagulopathies also. So with that, monitoring only on ACT may not be very accurate. What usually we do in that kind of patients is we try to do at least APTT once a day. We see what is the APTT level, and that time what was the ACT level, and we try to target the same ACT level. So we set the target. We set the target every day depending on the APTT. So we get the ACT result immediately, and we target ACT as per the whatever the APTT was in that particular day. Second thing, the patient is bleeding. It's very difficult to. The commonest thing which everybody blames is heparin. Because patient is on anticoagulant, patient is bleeding. But that may not be the story. The bleeding can be because of the coagulant factor, deficiency factors. So what will be the best if the patient is if patient is bleeding? I think then we have to go up on the coagulation monitoring in terms of 10A, or at least in terms of either TAG or sonoclot. That will be definitely a much better guide to tell us the platelet functions and other coagulation factors.
So while we have a patient who's bleeding, there's a tendency not to use whole blood but to give yellow products, and we keep giving them randomly while the patient is on ECMO. So Dr. Sunil, in your experience, should we as a team, an ECMO team today, should we focus on the giving of these random yellow blood products more than whole blood to our ECMO patient, seeing the hematocrit and the entire picture?
I think everything has to be in moderation and to address the need rather than giving them at random. For example, if there is no clotting or bleeding problems, keep watching the patient and keep ECMO going with that. Also with respect to the platelets. Platelet numbers are a marker for us, but they are not extremely important. People tend to tolerate up to 40,000, 50,000 as the number of platelets as well. Before we tend to transfuse on ECMO patients, especially when they are not bleeding. When they are bleeding, you have to take the numbers up and transfuse them. But if they are not bleeding, there is a role for watching further. In our situation, sepsis is another marker which brings the platelet numbers down and keeps them down for a significant period of time as well. So rather than giving them routinely, I suggest it has to be in moderation and to be addressed to the need. We were debating about this hemoglobin 13 to 15 or around 7. A patient may go through both the phases when he is oxygen hungry and you have to supplement, you are worried about provision of adequate oxygenation to the tissues, hemoglobin has to be high at that point of time. Once they are stabilized at a later point and still needs ECMO, then you can minimize that to 7 to 8 grams per deciliter. So both the stages can be seen in the same patient.
Very rightly said. In fact, now the cutoff triggers are coming down to as low as 7. It used to be 8, but cutoff triggers of 7 once, 4th or 5th day of ECMO maintenance, and the patient is well maintained on ECMO. You don't have to necessarily give blood. So we will talk about the restrictive transfusion as we come off. But Dr. Jagdish, is point of care tests on ECMO to be used only for research? And which do you think, if you've used them, is it 15 clot forming time? Is it any other parameter which tells you about the thromboembolism events or the beginning of a formation of an AKI on the ECMO patient?
So these viscoelastic tests are, gaining more and more importance in ECMO now. But there are not large studies which have been out and right proved them. So they have to be used when we have some issues, as Dr. Sundar said. When the platelets starts coming down, or if you have bleeding, these tests can be used. So do they really reduce the thromboembolic events? Further studies are required. So there is a recent study published by an Italian group where they manage anticoagulation with APTT and RTEC. So what they found was there was no great change in
Larson study. Yeah.
There was no change in the thromboembolic events. However, the dose of heparin used was less in TEC group. Coming to FIPTEM and MCF, again it's a costly test and can't be used regularly. But if once you have any bleeding issues, these can be used, and your products can be given accordingly.
Yes, so how do you correlate these tests, the expensive ones as well as, to my mind, the sonoclot PF-SON, less than or more than 0.9, that number also sticks onto the mind, because that number in a top patient who was put on integrated ECMO came off, and the PF-SON was less than 0.9. We were taking the patient for a re-ex. We didn't do a re-ex. We just gave to this patient with a PF of SON of less than 0.9. We kept giving 4 to 5 cryo, then 5 to 6 platelet concentrates, and then 2 units of FFP. So after giving 11 units of this, where the cryo were given more than the platelet and 1 or 2 units of FFP, the PF SON came up to 1.9. So when you see something like this, I think these tests, when you have excessive chest drainage outputs and you see sudden onset of bleeding somewhere with an impending tamponade, then you need to give your platelet concentrates in a better way. But these tests are helpful and should be there in at least a blood bank or a laboratory nearby to give you the results. Dr. Sundar, the coagulopathy on ECMO affects both sepsis as well as the SOFA scores. Could you please elaborate on this? This is a very recent article, and it says that the SOFA scores, sepsis and coagulopathy go hand in hand. Could you talk about your experience?
I was just going to say it's both cause and the effect. The commonest cause of coagulopathy on ECMO is sepsis. And then when you have a coagulopathy, it affects other organ systems. And SOFA, which is a sequential organ failure assessment, depends on 6 variables of each organ system. So once your platelet goes down, depending on the degree of how low it is, your score increases. So it affects on both. So once you have coagulopathy, it sets, the vicious cycle spiraling downwards.
Yes, it is one thing leading to the other, and this is where the role of a point of care test beyond the normal laboratory test comes in even handy. So you are measuring your SOFA score, you are seeing the coagulopathy on your rotum or sonoclot or TEG test. Probably the RTEG is the easiest to do. Less than or more than 0.25 is a very, very good number. Or any increase or decrease more than 2.5 to 4 times from the baseline value is a good number. Coming to round 3, and with Dr. Venkat telling us what and how do you avoid hemodilution and hypothermia on ECMO? If you avoid these two, does it prevent your patient from bleeding, especially on 7th, 8th day of ECMO onwards?
Regarding hemodilution, definitely it causes dilution of the coagulation factors. So we are very much mindful about hemodilution. Previously, said 7-8 years back, we used to do just a crystalloid priming. Then we realized that it is causing a drop in hemoglobin and also some amount of coagulation disturbances. So we started using 1 unit priming. After crystalloid priming, then we realized still an 800 cc of extra corporeal volume is not sufficient with 300 or 400 ml of blood. So now we do a total blood priming of the circuit in vitro after a crystalloid priming, so that the patient, the hemoglobin and other things do not change much. So we feel that maintaining here the thrombotic and coagulation factors by proper blood priming of the circuit in vitro before application on the patient may increase the stability, though we do not have a direct evidence, but we are realizing that that is the better policy.
Very right.
With
In fact, crystalloid and isotonic priming has become the norm, and it has changed the way we control the hemodilution.
Yeah.
And of course, at all times, always I think the ECMO oxygenators and the ECMO heat exchangers, the temperature is better managed than on a CPP machine. So maintaining your temperature is very important. For hypothermia, what would you say?
I would say that though it does not drastically alters the result, after the patient is put on ECMO, you may have 1 hour or 2 hours to connect to a heater cooler unit. Immediate effects are not seen, but if it is hypothermia, the oxygen demand increases by 11% for each degree rise of centigrade. So for special condition where you want to keep hypothermia in CNS patient, otherwise I would advise, as soon as you are free with the ECMO application, better put on a heater cooler unit to maintain normothermia.
Yes, around 36, 37 is the best temperature. You would agree?
Yes.
So Dr. Pranay, would you agree that there is a role of protocol guided bleeding management in ECMO patients?
Yeah, definitely. There has to be a protocol guided management in terms of you have to know what kind of ACT you want to manage. Every day PTT, every day PT with INR, that should be baseline. And then after that, if there's a bleeding incidences, then you have to go for a point of care test like either a TAG or sonoclot. That will definitely help you to find out the cause of bleeding. More you delay and you accept the bleeding and keep on blaming heparin, you are probably decreasing the chance of patients coming out of ECMO, because then bleeding, multiple transfusions, again lung injury, again sepsis. So I think we have to be more aggressive and protocolized in management of bleeding.
Very rightly said. In fact, most of the successful papers coming from the West today are dealing with protocols and algorithms, where if you have this much of bleeding, this is what you give, this is the temperature to be seen, this is the basic cess and the soda bicarb to be given. These protocols and algorithms have come up, and they are on the go-to card near the ECMO machine itself, so that the nurses, the perfusionists, and everyone as a team can see them and keep being guided by them. So Dr. Sunil, with your experience, do you think there is a role of restrictive blood transfusion policies today? A lot of guidelines today are talking about moving from liberal transfusions to restrictive blood transfusions and blood practicing. Can we in India, where there is no paucity of blood, can we adopt it in India? And is this fathom that no coagulopathy, no blood, is it feasible in an ECMO patient?
I think it is the way forward, and there is some sense behind it. So we need to adopt this. It has to be in the mindset of the ECMologist. Slightly out of the way, Poonam, when we were managing patients of Jehovah's Witness, by minimizing the blood loss with investigations, etc., we realized it's not very easy, but still it is possible to maintain them. So it is a mindset of the ECMologist, mindset of the physicians to minimize the blood loss to the extent possible and aim for hemoglobin, appropriate hemoglobin needed for the patient at that particular stage of ECMO.
Very well said.
Yeah.
Very rightly.
So it is possible when there is no coagulopathy, consider no blood, and there are studies available as well. Bob always says hemoglobin is the key for oxygenation. Yes, it is the key, but you have to use it when it is needed, and the patient is stable, you can de-escalate little bit as well.
I agree. In fact, in one of the major talks that Dr. Robert Bartlett gives on physiology on ECMO, he always, correct me if I'm wrong, Dr. Sunil, he always shows the movement of the hemoglobin with the oxygen dissociation curve to the right is what helps the patient recover from any ECMO. And that's what the intensivist on the ECMO patient should be doing. So, restricted transfusion practices is the norm today, and it should be practiced by each and every one of us who's on ECMO. Dr. Jagdish, then going on as a corollary to this, do you think that a goal-directed transfusion algorithm with point-of-care tests, can they implement on every type of ECMO today? Do you have an experience on the same?
Of course, they can be implemented. We are not using much of these tests before COVID. After COVID and so many ECMOs, we have now routinely started using TEG. So at least one TEG we are doing for all these patients, and accordingly managing the transfusions. Of course, it can be used in both VA and VB ECMOs.
Do you do it setting a goal in mind that I want my, if you're doing SCVO2, I want my SCVO2 above 70%. That's what we do. If we have put in a precept catheter, or maybe a mixed venous return if you have a PA catheter, or maybe a PO2 value, something. Do you have a goal in mind?
Yeah, but routinely we don't put PA catheters for these ECMO patients.
No, I'm talking of cardiac patients going on ECMO in our scenario.
So our patients mostly are on, cardiogenic shock patients who go on VA ECMO, or recently in VV ECMOs for COVID patients. So, PO2, we try to maintain around 60 to 70. And as such, as Sir said, hemoglobin, it depends upon the stage in which the patient is on the ECMO. And platelets, of course, if platelets are less than 40 and the patient is not bleeding, we don't usually intervene. Suppose if the maximum amplitude in the TEG is low, then we transfuse platelets. And of course, fibrinogen is less than 200, then we give cryo. So, it is all individualized to a particular institution and practices. There is not a consensus guideline for transfusion.
You're right. Dr. Sundar, with your experience on transplant patients, do you practice restrictive transfusion policies with goal-directed protocols in mind?
Thank you. That's quite a tricky question. Well, the whole philosophy of transplant and using ECMO as a bridge to transplant is to make sure that the other end organs are preserved until such time you get the organ. Now, the most common organ requiring an ECMO bridge is a lung transplant. Now the whole philosophy is, yes, we are all alive, we concede, restrictive transfusion policy has shown mortality benefits in the ICU, and scaringly so, the intensivists start reducing the transfusion trigger. I remember it was 9, it has become 8, it has become 7. I'm worried it is going to become 6 or 5. Well, it might be. So there is a scientific basis for it. We are not saying no. But in the context of waiting for a lung transplant, I am more worried that I need to maintain my liver, my kidney, all my organs optimally. And lung transplant is one which is different from other organ transplants. Liver, heart, kidney, irrespective of the patient's muscular status, works when you release the clamp. You can have a totally paralyzed patient, the heart transplant is going to work well. But the lung transplant, the person has to breathe in and breathe out. So he needs muscular activity. So when it is coming to lung transplant, I am a little keen to maintain the oxygen levels. So I would not err so much on the restrictive policy while I am alive. That restrictive policy is good. It has been proven in the general ICU things. In lung transplant, there is not much evidence out. And at this point in time, I'll probably tilt towards liberal transfusion policy.
I'm so happy you're so honest about it, because most cardiac surgeons, even for any kind of transplant that we do, are still believing in the liberal transplant policies of transfusion. Why? Because they want a hematocrit which would make the post-op heart function and pump. And as Dr. Sundar rightly pointed out, the lungs are different from the kidneys and the liver and the heart. They need to have tissue oxygenation exchange, and for that, liberal would be there, but I'm sure we'll soon be seeing a paper, maybe from the Chennai group itself, on restrictive lung transfusion policies for lung transplant. We come to the last round, and I'm glad we are in time and our people are giving us the right and to the point answers. We come to a very controversial round, and this is a round of using concentrates, which we in India are not so aware of at present, but the whole of the European world uses concentrates, factor concentrates, 4-point factor concentrates. They are all the norm today. So if you ask Dr. Venkat Goel your experience on cryo versus fibrinogen, when you have hypofibrinogenemia, which is so very common on all kinds of ECMO, we saw it in COVID. What is the role of factor concentrates, especially the fibrinogen concentrates, in the cardiac VA ECMO?
Basically, a thrombotic circuit is a disaster, and therefore we need to maintain a balance between FFP and cryo and fibrinogen. There is not much difference as per se. It is just a more purified, concentrated form, and it requires a battery of tests to reach to a conclusion that, of course, this patient requires cryo and this patient requires fibrinogen, because that is much more an activity of mechanical circulatory devices than only an VA ECMO. Because of high flows in VA ECMO, usually clotting tendency, other things are not there because the circuit is in a fluid state. But in artificial devices, they play a big role.
So you would think of factor concentrates, because Europe has come up with a lot of papers in recent times saying a lot of thrombosis because of liberal transfusion of fibrinogen concentrates.
But,
Would you agree on that, Dr. Pranay?
Yeah, see, probably getting the fibrinogen, pure fibrinogen concentrate is going to be little difficult. What we easily get is a cryo. So usually if the fibrinogen is less than 100, we transfuse cryo only rather than a fibrinogen concentrate.
No, many
Availability
hospitals
is
I know in
difficult.
Delhi are taking the Octa Pharma prothrombin concentrates as well as the fibrinogen concentrates.
Okay.
So the use has started. But would you advocate, when so much of thrombosis is coming in and you have a pack of factor concentrate of, let's say, prothrombin and another single donor platelet, which one would you choose?
I didn't get the question.
If you have concentrates, fibrinogen or prothrombin or platelet, and you have on the other hand a cryo or a single donor platelet for thrombocytopenia or for hypofibrinogenemia, which one would be your first choice?
If it's available, then we go for a specific concentrate, unless we are sure that only this is the problem. But usually it is coagulopathy is more of a generalized coagulopathy rather than only a specific one.
I would agree there, because it is the tissue factor induced, it is the common pathway, the tissue factor pathway and the extrinsic pathway, where activation of factor 7, factor 8, factor 9, 10, it sets up a cascade of thrombin. So if you know that it's a generalized coagulopathy, then use concentrates, but as Dr. Sunil said, everything in moderation. Do not go overboard because they are available. So use all your antifibrinolytic and your factor concentrates, even your cryo and your single donor platelets, by doing tests after every 2 to 3 hours to see how they are reacting in the body. Dr. Sunil, a question to you. When no coagulopathy, consider no blood. You just mentioned this. Is it feasible in our patients on ECMO? I'm coming back to this question because it disturbs you. You seeing a coagulopathy, you want antithrombin 3 or you want some blood, you want some yellow product. Something like this is there in our minds. We are intensivists. Would you let your patient be?
You answered the question partly, Poonam. It is in the mind of the mindset of the intensivist or the ECMologist who is doing it. So if we are primed to this idea of restriction transfusion policy and use it whenever it is needed but not otherwise. So that is the way I think it is possible. When there is no coagulopathy, consider no blood. No, whenever there is a need for any product, as I identify that factor, then only I will give it. Otherwise, I will restrict the use.
Very often on ECMO, we see lymphopenia, neutropenia, especially lymphopenia, very, very common. We saw it in our COVID patients. And do COVID-19 patients bleed more on ECMO? Dr. Jagdish, your experience on it, and the panel is also free to talk about their experience on ECMO COVID.
So most of the studies, initially these patients are more prone for thrombosis, so they are giving higher doses of heparin. So that is one of the causes for bleeding maybe. And what we have seen is in COVID VV ECMOs, there are more intracranial bleeds compared to VV ECMOs for other patients waiting for lung transplant. And there are more number of retroperitoneal hematomas and muscle hematomas we have seen in a subset of patients, and the exact cause is not known. Yes.
Dr. Sundar, your experience on ECMO COVID-19?
Well, yes, my experience was, apart from the increased resources needed and more labor intensive, the ECMO in COVID and non-COVID was not so different. Was what I felt.
More resources.
More resources.
Dr. Sunil, yours?
We have observed in 2016, between 2010 to 2016 as well, when we were dealing with the H1N1, the same pattern about hypercoagulability and need for increasing doses of anticoagulants. The same practice is being reflected, observations in COVID-19 ECMO as well. So this might be one of the reasons why the patients are bleeding more.
Did you see more lymphopenia and neutropenia also on patients of COVID-19 going on ECMO?
We do see, and it may be a reflection of this being a viral infection and sepsis.
Dr. Pranay, you dealt with a lot of them.
In first phase of ECMO, we see a more bleeding, but probably that was a time where we thought about, okay, there are more thrombotic tendencies, and we used to give them, little on higher on SCT, or we intend to keep heparin more. Second thing, many of them, because of cytokine storm, they received cytoso filters and that. So probably that also adds into the incidence of bleeding. Thirdly, usually we see a COVID ECMO as a long run. So because of long run, there are multiple episodes of sepsis, thrombocytopenia. And if you see statistically altogether, then you find that bleeding incidences are more. But because it was quite a prolonged ECMO, and because of prolonged ECMO, there is some coagulopathy, and that is the reason there was bleeding more.
Dr. Venkat, your last thoughts on this?
That neutrophilic lymphocytic ratio in COVID has been a very important marker for the severity of COVID. Now, how much that lymphopenia has affected ECMO, that we have not studied, but I think it is part and parcel of it.
I would just like to briefly, I agree with you. We saw a lot of lymphopenia in all our COVID patients, and we were doing the neutrophilic lymphopenic ratios. But I had two relatives in two different hospitals at the same time, both COVID, one government hospital, one private, and I was asked to do ROTEM for them because we were doing ROTEM on ECMO patients as a research tool in which we were doing platelet function analysis. So the platelet functions make you give 3 reagents, TRAPTEM, ARATEM and ADP-TEM, and you see the area under the curve. To my surprise, both of them bled. On day 6, one of them, on day 9, the other. And the area under the curve from a good area of 1.8, 1.9 in one, 2.4, 2.8 in one, came down to less than 0.1, which means it came as a real straight line, which is the line that you get on a sonoclot when you have heparin effect. So it means your intrinsic pathway as well as your heparin pathway with the heparinase bead being used was affected. So I just told them it's a corollary. Dr. O.P. Yadav was one of the cardiac surgeons involved. Dr. Sundar knows him. He said, let's stop giving heparin. So we stopped heparin. The patient was monitored on low molecular weight heparin. Did the same to the other patient in Safdarjung Hospital. And to our surprise, just on low molecular weight heparin and an anti-factor 10A, which we got done from one of the private labs in South Delhi, we saw a 0.4 and a 0.39 10A levels maintained, and both the patients are alive today. So to our mind, when they bleed, think of another anticoagulant is what I would like to say before we end. And COVID-19 patients on ECMO do bleed more. And the time period is between 6 to 10 days. Arpan sitting there would be able to give more examples. Arpan, your call on it? Can someone give a mic to him, please?
Experience-wise, it is it's contrary. Initially, he was breathing a lot, but as we have with the day is increasing and all this, they don't bleed on that much way. And I was also sharing yesterday that we have ran lot of heparin-free ECMOs because platelet was 35,000 and we didn't transfuse, so no need of heparin. And we have done TAG also. Few patients have abnormal TAG, but most of them are within fine, okay.
But this platelet function test coming to a straight line was a very good early marker to say stop heparin for some
time. So
time.
they bled from your...
they were bleeding from the mouth, from the endotracheal tube.
Okay.
And one of them, the intensivist was smart enough, extubated the patient on day 10. And the patient is alive. It's been more than 111. It's 3 months now. So it's a very good call to take a call of being slightly different, because we don't know how these viral infections are going to be. And the immune host and the defense mechanism in everybody is so different. But yes, heparin-free COVID-19 ECMO is reported. It is there in literature. And that should take us also to a period where we must know when to stop the heparin. And just as we use the Bull's curve of how to neutralize the heparin with protamine and how much of protamine to give, and the patient blood management today is saying that you give 1:1 protamine and not 1:1.4. I'm sure the days are there when we are going to stop heparin on a particular day.
Yeah.
Maybe we are going to be there. The last question to you, Dr. Sundar, is what is the potential of implementing patient blood management and considering the health economics in an ECMO patient in a country like India? And where are the financial resources for doing a patient blood management on ECMO in our country going to come from? Where is the money going to come from? Yes. The patient?
A tricky question again.
So you're the surgeon, sir. So all the surgeons make up all the tricks in the OR and the ICU. So they know how to
I
handle.
suppose, if the evidence is out there that when there is a restrictive transfusion policy with better patient blood management, the outcomes are better. How much we can extrapolate to ECMO, evidence is being synthesized now. It was quite an interesting topic, when you did mention about PBM. To go back, it's been there for many decades, but you had a recent article now in the Annals of Thoracic Surgery. So there are many ways where you select the patient well, prepare the patient. If you are operating, minimize blood loss. It's pretty much like operating on a Jehovah's Witness. If you do that, obviously the cost will come down. More importantly, the healthcare cost, the mortality is less, the stay is less, so that indirectly further reduces the cost. In general, in ECMO, I think evidence has to be synthesized to see, because ECMO is a life-saving therapy, but comes with a cost. It is not universally available everywhere, and apart from hospitals like AIIMS and a few other hospitals, the predominant ECMO centers in our country are private hospitals. So yes, we need to think of these and financial resources. Our Chief Minister just yesterday announced that the first 48 hours of an accident victim will be treated free of cost either in a general or in a corporate hospital. And the subsequent. So probably governmental policies like this would go a long way in improving it.
In fact, in the West, wherever they have PBM, it is the insurance through the government. The countries which are able to afford a good patient blood management policy, most of them in the West are doing it through insurance policies. And the resources do indirectly come from the patient itself. And this is where the fallacy lies. If it comes from the government, and the government is at the backbone of providing PBM, we will not be ruthlessly using so much of blood, so many tests, minimizing blood loss as we do for Jehovah's Witness, and maintaining maybe at a low trigger and a low cutoff of anti-10A 0.28 is fine, or maybe anti-thrombin 3 level less than 60% is fine. I don't need to keep giving anti-thrombin 3. The cost of the vial may be 1,200, but we gave it to 3 of our patients and we lost the patients because of AKI. So you don't know, as Dr. Sunil mentioned, you do not know how these factor concentrates that are coming in are going to cause the thrombosis, are going to cause the renal problems, and are going to be more detrimental than useful. and having a short, swift ECMO and cutting off ECMO at the right time would be the best to do PBM. That would be my... Dr. Sunil, your last words before we call it. Our time is up.
Thanks, Poonam. The take-home message for our session today, I would like it to be this way. Anticoagulation practices on ECMO are patient-specific and they should be tailored to the needs of the patient. As we brought it up, please see what is the coagulation status of your patient when the patient is being put on ECMO, and if the coagulation profile is already compromised, then you can go on with no heparin or minimal heparin and monitor there from there onwards. That is one take-home message. At least we had one patient in pediatric population, in neonatal population, who arrested following going on to ECMO. And the reason for that was hyperkalemia. Blood potassium on the transfused blood was 11. So some things like this do happen, and you can learn from others' experiences also. Just doing a blood gas on the blood you are going to transfuse to tell you about the potassium in that blood. That will help you as well to tell you what you are giving to your patient. Thank you, Poonam, for this opportunity, and thank you.
I thank all
Bala,
the
Suresh,
panelists
team.
and I thank the organizers for giving us this opportunity. Thank you so much.